Sepsis. Now, sepsis is a clinical syndrome resulting from a dysregulated systemic inflammatory response to infection. The international definition is evidence of SIRS with cardiovascular dysfunction in the face of probable or proven infection. It is caused by a pro-inflammatory cascade that can lead to tissue injury and multi-organ failure. In terms of sepsis, the important thing to remember that there is a clinical spectrum of illness similar to adult definition. The only difference in PEDS is our PEDS-specific vital signs. So for SIRS, it is 2 out of the 4 of temperature instability, so either hyperthermia or hypothermia, an increase in heart rate greater than 2 standard deviation for age, or lower heart rate if you're under a year old, and tachypnea greater than 2 standard deviation for age, and an abnormal white blood cell count or immature neutrophil count. So sepsis can be a range from SIRS sepsis to severe sepsis and septic shock. But why do we care about sepsis in kids? First of all, it's one of the leading causes of childhood deaths worldwide. Secondly, it's also one of the leading causes of multi-organ failure in kids. Unfortunately, there has been no change in the mortality rate, or very little, over the past 30 years across the world. As well, sepsis is very expensive, and it leads to a long length of stay in a hospital. And evidence-based guidelines do exist that, if implemented, could actually improve outcome. So can we prevent sepsis? I'd be remiss with my training in public health not to mention the 3 tiers of prevention. So primary prevention includes sanitation, nutrition, and immunization. Now, for some of us who live in North America, parts of Western Europe, Australia, we're now faced with pockets of population who choose not to immunize their children. But that's for another topic, for another time, but it's a reality for a lot of us out there. Secondary prevention, you can be giving antibiotics, prophylaxis to the immunocompromised. But you're saying, you know what, this is all great, but I'm an emerge doc. Maybe I don't look like that, but... So, this slide seems straightforward enough, even though you can't probably read it, but you can read the golden hour, right? We know that sepsis is a time-critical emergency. In kids, it can rapidly progress. It requires prompt and early recognition, timely antibiotics, aggressive treatment. It seems straightforward. But in kids, the problem is that kids compensate, and they hold on, and they look good for a long time until it's too late. So kids with life-threatening infection often present with fever and excessive persistent tachycardia. Tachypnea, tachycardia, signs of worsening perfusion all precede hypotension, as was mentioned earlier in another talk. Hypotension is a late, ominous sign, and that means usually when you see it, you're going to have to prepare for cardiopulmonary collapse. So our job as emergency physicians is to prevent that from happening, to prevent decompensated shock. So, who requires a lower threshold for the initiation of treatment for sepsis? Who says A, children under 3 months of age? Or B, children with chronic disease? C, children with recent surgery? D, the immunocompromised? None of the above? All right, so I heard people say all, indeed. But how do we go about practically doing this? Now, the Severe Sepsis campaign in 2012 advocated for using one of these screening tools. The idea being you want people to be recognizing sepsis early on, and anybody can be doing that, from your triage nurse to your resident. And if actually implemented these screening tools, it would be great because you would actually expedite the treatment of sepsis and septic shock. The only problem and disadvantage, though, is that if you're in a center where you see a high pediatric volume, there can be sort of a high rate of false positive, and then that would lead to basically trigger fatigue, the sepsis trigger fatigue. And then you kind of lose the interest of your workers, your colleagues, etc. So Sapansky et al. Tried to design this pediatric severe sepsis screening tool using slightly different vital sign guidelines. So they used greater than 2.2 standard deviation for heart rate and greater than 2.8 standard deviation for breast rate. Unfortunately, this is not yet prospectively validated, so I don't think we can necessarily use it yet. But probably the rule of thumb is not a bad one. So heart rate increases approximately 10 beats per minute, and rest rate by 5 breaths per minute for every Celsius degree of fever greater than 38. So in the meantime, perhaps it's sufficient for your center to use just a simple, basic triage tool that can follow the patient throughout their emergency department stay, looking at abnormal vital signs, high-risk conditions, and signs of poor perfusion. Now, the American College of Critical Care Medicine, back in 2002, developed these sepsis guidelines. They refined it, revised it in 2007, and then published that in 2009. And it has been incorporated into the Pediatric Advanced Life Support Algorithm, or PALS algorithm. And this is also the guidelines that the Severe Sepsis Campaign based their pediatric considerations. Basically, they base it all on this. So what does it actually ask for or tell you to do? It's pretty simple. Guidelines call for aggressive fluid resuscitation up to 60 cc's per kilo in 15 minutes compared to adults. Kids require proportionately more fluid. Second, if the short shock persists despite good vasoactive agents should be used. Back in 2003, Han et al. Looked at, retrospectively over 9 years, look at all the transport to their tertiary care center. And they found that for those who did not adhere to PALS algorithm, that was associated with a 50% increased odds of mortality. They concluded that early recognition and aggressive resuscitation by community physicians in peripheral hospitals can save lives. Oliveira et al. Followed with showing that mortality is both fluid sensitive and time sensitive, meaning that where mortality increases with decreased amount of fluid, and mortality also increased with a delay in giving fluid. Now, the first speaker already touched upon this. With fluids in septic shock, is it either all feast or famine? These guys took on a huge project really. It was a non-blinded, randomized controlled trial, took place in 6 centers in 3 countries, just shy of 3 years. They took in kids 60 days to 12 years of age. They looked at presence of all 3 of fever, impaired consciousness or respiratory distress, and 1 sign of impaired perfusion. They excluded kids with severe malnutrition, gastroenteritis, and other types of shock. You looked at this already briefly. So they enrolled over 3,000 patients, but only 29 of them had severe hypotension. The rest were randomized to either fluid bolus of normal saline, fluid bolus of albumin, or no bolus. As you heard, the trial was actually stopped early because what they found was there was an increased mortality, 48-hour mortality in those who got fluid. Now, does that mean that everything we learned about fluids and septic shock for kids, fluid has, should we throw that all out? And the answer is no, not so quickly. No changes were really made to international guidelines based on this study, mostly because of their patient population, their inclusion criteria. People weren't so satisfied that it actually met criteria for septic shock. As well, the underlying cause, as you heard, about 50% of patients had malaria, about greater than 30% had hemoglobin of less than 50, greater than 80% had respiratory distress. However, in face of all this academic critique, the authors actually published a secondary analysis and found that malaria and anemia were non-contributory. But secondary analysis has always been taken with a grain of salt, right? So I think the bottom line is we still need future studies. At McMaster in Hamilton, Ontario, we have a pilot study going on, pilot randomized controlled trial looking at kids with septic shock. So kids who have been given 40 cc's of fluid already, they're randomized to either a fluid sparing arm or a usual care arm. So time will tell whether that trial will actually tell us anything, but certainly the patient population would be more similar to ours. But the answer to, can I give too much fluids to kids in septic shock is actually yes. So kids, but you can just keep reassessing them, right? So in children, you can listen for crackles, you can check for hepatomegaly, and if you notice anemia, you should be giving them blood instead. Paul et al. Looked at something that now we think is pretty obvious, which is that does adherence to the PALS guideline decrease length of stay? Not surprisingly, the answer is yes. But what was interesting in that study is that the adherence rate itself was really low. It was about 35% in this tertiary care urban center. So they wanted to, they being very ambitious, more ambitious than I, 2 years later came out with another study. And they focused on quality improvement methodology, so repeated plan, do, study, act cycles in their hospital, and they found that they could actually improve adherence, reduce mortality, and concluded that care bundles actually simplify, streamline the process, and thus speeding up treatment for septic shock. So that's how the pediatric sepsis 6, similar to the pediatric sepsis 6, and the severe sepsis campaign in 2012, all basically are wanting everyone to complete 6 basic elements in 1 hour. The first one being provide oxygen. Kids have a lower functional residual capacity, especially in the face of sepsis and septic shock. So they sometimes you might have a lower threshold to intubate. But these days, you can actually increase their functional residual capacity simply by providing high flow oxygen as well as nasal CPAP. The other thing is rapid IV access. Now, IV access in kids is hard, even in a tertiary pediatric center for a kid in septic shock. So don't hesitate to use an IO. Because you need access for what? For antibiotics, although of course you can be giving that IM, don't forget that. You need your IV access to give them fluids, as we had already mentioned, as well as your inotropes, be it dopamine, epinephrine, and also you need to be asking for help. So if you're in a peripheral hospital, asking for tertiary care center help or a subspecialist to help, just ask for help. And what is the end point? What are we trying to do? So you want to be continually reassessing your patient for these goal-directed endpoints. A normalized cap refill time of less than or equal to 2 seconds. You want normalize your blood pressure. You want to have normal peripheral pulses as well as central pulses. You want to have warm extremities. You want to maintain a urine output of greater than 1 cc per kilo per hour. And you want to have eventually get normal mentation within the hour if possible. Now we all know that all the guidelines and bundles that we're talking about is wonderful and works, but it might not be applicable if you don't even have, depending on what resources you have. So sepsis treatment really needs to be based upon what resource you have. So that's why there's a global sepsis initiative that has come that looks at how you treat sepsis, or rather, how you should treat sepsis depending on what resources you have. And so there have been different studies all around the world. For example, one study in India reduced neonatal mortality with just providing a healthcare worker and IM antibiotics, all the way up to a study in Rotterdam and St. Mary's, where they improved mortality with resuscitation following guidelines similar to what we had talked about throughout this presentation. So there's a whole range of what you can be providing. Now, hopefully by the end of this conference, some of you might choose to go back to your home, to your country, to your emergency department, and become a leader in sepsis prevention in PEDS. You might learn about sepsis and quality improvement, to establish baseline processes and outcome measures, to demonstrate need for improvement in your center. You might want to ask for buy-in from leaders and stakeholders to develop some institution-specific care bundle protocols. You want to educate your stakeholders and be prepared to remediate errors that are going to happen and to anticipate the obstacles that are bound to come your way. And if you think that sounds really intimidating and there's no way you're going to do that, there's actually a lot of resources out there online that you can follow. So one of them would be the survivingsepsis.org website down there. Another one would be the agreetrust.org website, and that gives you basically step-by-step outline of how to create or evaluate clinical practice guidelines. So I think for those out there who might be coming from resource-limited setting or even peripheral hospitals, this is all something that you can take on if you feel moved to do so. And in conclusion, really keep calm, do the sepsis 6. Thank you.